Receptive, Expressive, Emergent Language Test, 3rd edition by Amy Weinberg. This test was written by Kenneth B. Boza, Richard League, and Virginia L. Brown. The test was published in 2003. The test acronym is REEL3, and the price of the test is $121. The test is published by ProEd Incorporated, and the components of the instrument are the examiner's manual and the examiner record booklet. The purpose of the Receptive, Expressive, Emergent Language Test is to identify infants and toddlers who have language impairments or have other disabilities that affect language development. Also, the test identifies any significant discrepancies between receptive and expressive processes of emergent language. The appropriate use for the Receptive, Expressive, Emergent Language Test is infants and toddlers from birth to 36 months. The primary language at home for those being tested should be English. If English is not the primary language, care should be taken in choosing this test. If the test is used, an interpreter should be provided, or the examiner should be familiar in both languages. The sample size used to standardize this test was 1,112 infants and toddlers who were between 0 and 29 months old. 54% were male and 46% were female. The sample came from 32 states from both rural and urban populations. The ethnic characteristics of the sample were white, black, and other, and the racial characteristics were Native American, Hispanic American, Asian American, African American, and other. The education level of the parents or caregivers ranged from having a master's or professional or a doctorate degree to having less than a bachelor's degree. The test had construct validity in that the raw scores correlated with age, and children with speech-language impairments had lower scores than children without disabilities. In addition, different gender and ethnic groups scored within normal range, and the results that measured cognitive ability correlated with intelligence. The subtests were also intercorrelated, and there's a strong correlation on the performance of the items with the total score made on the test. The test had content validity because there are detailed rationale for the items and testing formats for each subtest. A discrimination was used to help select good items for the test. Item difficulty was used to identify items that were too easy or difficult, and differential functioning analysis was used to show the absence of bias in the test items. The test had concurrent validity because it was tested with the Developmental Assessment of Young Children Communication subtest and the Early Language Milestone Scale 2nd edition. The standard scores from both tests were correlated with the scores from the Receptive, Expressive, Emergent Language Test. The test has predictive validity because the resulting coefficients from testing the Receptive, Expressive, Emergent Language Test with Developmental Assessment of Young Children Communication subtest and the Early Language Milestone Scale 2nd edition fall within range of moderate and high correlation. Test-retest reliability was proven by testing 44 infants between 0 and 36 months twice. The time between the tests was 2 weeks. The coefficient for the two studies was greater than 0.75, which shows there is little or no sampling error. Inter-judge and intra-judge reliability is shown using the kappa coefficient. The mean kappa for the receptive language subtest and the expressive language subtest was 0.99, and any kappa of 0.75 or better is considered excellent. There is no time limit for the test. The time required to give both subtests varies from 20 to 30 minutes. Clinicians administering the test should be familiar with the content of the examiner's manual. They should bring to the test the examiner's record booklet, the examiner manual, and a sharpened pencil with an eraser. The test should be administered in a quiet, comfortable, and non-destructive environment, and the examiner should sit next to or across the table from the informant during the interview. Rapport should be established prior to the interview. To administer the test, the examiner asks a series of questions that require only a simple yes or no answer, and records answers in the examiner record booklet. Supplementary questions can be asked when the subtest answers are ambivalent where the clinicians want to find out something about the parent's or caregiver's language or to gain insight into the child's language development. The receptive language subtest measures the child's current response to sounds or language as reported by a parent or caregiver. There are 66 items that are answered by yes or no responses, and the standard score is reported as receptive language ability score. The expressive language subtest measures the child's current oral language production as reported by a parent or caregiver. There are 66 items that are answered by yes or no responses, and the resulting standard score is reported as expressive language ability score. Raw scores, percentile ranks, standard scores, and age equivalent scores are provided, but percentage scores are not found. The test helps to identify infants and children who are acquiring language at a delayed pace and also determines any discrepancies between receptive and expressive language. Also, the test allows clinicians to look at receptive and expressive language separately. The test is simple and quick to administer and has good validity and reliability. Also, this test has been standardized. To prepare, the examiner should read over the examiner's manual and the examiner record booklet. They should be familiar with the questions being asked in the record booklet, practice administering the test, they should know how to score the test, and they should be familiar with expressive and receptive language. Some limitations are parents and caregivers report information, so there is a possibility of reporter bias. Also, the clinician does not get to observe the child's language or behavior. Some cautions are all questions should be asked clearly. Also, the test should be administered in a quiet room where all questions can be heard. English should be the spoken language at home, and if not, accommodations should be made. The test does not diagnose a disorder, but rather lets the clinician know if receptive and expressive language are not emerging properly.